Hey, good evening, everyone. As you know, my name is Abubaker Madani. I'm the neurologist in DHA and working private as well. Our talk today would be on headache update series. So the floor is yours, Dr. Khalid.
Thank you, Dr. Abubaker. Thank you for asking me to say a few words about one of my favorite subjects, which is migraine, and specifically migraine prevention. And I'll try to update some of the information. Dr. Abubaker has concentrated on a few cases and a specific preventive agent. I will talk in general about all migraine prevention. As has already been mentioned, migraine is the third most common disease in the world. If you wonder what are the top two common diseases in the world, well, they're dental caries and tension type headache. Migraine is the second leading cause of years lived with disability in the 15 to 45 age group. And this is according to the Global Burden of Disease study from the World Health Organization. Half of those with migraine do not carry a diagnosis of migraine. This data comes from a very famous epidemiological studies from the Bronx in New York. Half the people with migraine do not know they have migraine. They think they have headaches or sinus headaches or tension headaches or headaches because of the neck pain or headaches because of demonic possession. I don't know what they think, but they don't know that they have migraine. Nobody ever told them and they never suspected it. And of those who have migraine and who are eligible for preventive therapy, 40% of them are not on any preventive therapy. And if patients are candidates for preventive therapy and are not on preventive therapy, this is a high risk for chronification of migraine, which is a highly disabling condition. So, how do we approach migraine? Well, our main reference is the International Classification of Headache Disorders, which is a classification scheme put together by the International Headache Society, the third edition of which was released in January 2018. And it defines migraine as follows, and I think Dr. Abubaker already went through this, but we need to be clear what we're talking about. So migraine headache is a headache that lasts between 4 and 72 hours, untreated or unsuccessfully treated. So a headache that comes for an hour or two and goes away by itself is not migraine. Migraine can go beyond 72 hours. In that case, we call it status migrainosus. But the typical migraine attacks last between 4 and 72 hours. Cluster headache, for example, another type of severe debilitating headache, lasts between 15 minutes to 180 minutes, 3 hours. The headache should have at least two of the following characteristics: a unilateral location, a pulsating character, moderate or severe pain intensity, and the pain should be aggravated by or causing avoidance of routine physical activity. So walking around doing normal chores is bothersome, is painful. You need 2 out of these 4. In addition, during the headache attack, you should have at least one of the following, if not both: nausea and or vomiting. And if there's no nausea or vomiting, you should have photophobia and phonophobia. This is how we diagnose migraine without aura. Okay, now that we know how to diagnose migraine, which, as Dr. Abubaker stated, affects 1 billion people worldwide, somewhere around 12% of the population. What are we going to do about it? Well, we're going to treat it. There is no cure for migraine. In Western medicine, there is no cure for migraine. Everybody is looking for a cure. If you find one, please let me know. We will win the Nobel Prize together. All right. I do have patients that come to me and they tell me, during my teenage years, I had migraines for 3, 4, 5 years. They were really bad. Then nothing really for the last 10, 15 years. And now they're coming again. That happens. We don't know why, but it does. We know there are triggers. We know there are hormonal influences, but we have no cure. Sometimes a patient who has migraines may pursue a certain intervention like acupuncture or hijama or some manipulation, and then suddenly their headaches go away and they will swear to you that this is the way to get rid of the migraines. I cannot argue with them. It worked for them, but for the majority, 99.99% of people, it will not work. It may help, but it's not a cure. So the principles of therapy are really 3-pronged: education, lifestyle modification, trigger factor avoidance, acute therapies, which I will not discuss today because today's talk is about preventive therapy. When we talk about acute therapy, it's non-specific or migraine specific. The non-specific therapies are well known to all of us: paracetamol, non-steroidal anti-inflammatory drugs, and in very, very rare circumstances, narcotics. The migraine-specific therapies are triptans, which have been around since the mid-1990s, and that mainly includes triptans, and that is serotonin 1BD receptor agonists. Recently on the market that have been approved are the ditans, serotonin 1F receptor agonists. The advantage of having a serotonin 1F receptor agonist is that you don't have any vasoconstrictive side effects, and therefore you don't need to worry when using these agents in patients with, for example, coronary artery disease or cerebrovascular disease. Recently, there has been some concern raised about the use of ditans with SSRI type medications. There's one agent that is approved and is available in the UAE already, and that is lasmiditan or Rayvow. Another group of acute migraine therapies include the GPANs, and they are CGRP-based type therapies for the acute treatment of migraine. There are 2 such agents approved in the US. One hopefully will be approved soon in the UAE. When it comes to preventive pharmacotherapy, we have 2 major classes of medications. Repurposed drugs, these are all drugs used for many different reasons and are used in migraine prevention, and CGRP-based therapy or calcitonin gene-related peptide-based therapy. You see it's mentioned both under acute and preventive therapy, and we'll go into a bit of more detail about that. So who needs preventive therapy? And again, this was addressed later, but it may be useful to talk about it again. In general, people experiencing 4 or more headache days a month with some level of impairment qualify for migraine prevention. Somebody having 2 days per month with severe disability, persistent nausea, vomiting, in bed, not responding to anything may also qualify for preventive therapy. Somebody having 5 days per month for which their headaches completely go away with a non-steroidal or a simple triptan may not need preventive therapy. But in general, if somebody is experiencing 4 or more headache or migraine days a month, we start talking about the potential use of preventive therapy. There are special cases of rare episodic migraine that happens maybe once a month, once every couple of months, for which preventive therapy may also be appropriate. Things like hemiplegic migraine, brainstem migraine, and prolonged aura. So let's talk again about preventive therapy. And we said there are 2 classes of medications, repurposed drugs and CGRP-based drugs. Repurposed drugs are the ones we are all familiar with. We've used them for decades. These include the beta blockers, the antidepressants, and here we're talking about tricyclic antidepressants such as amitriptyline and nortriptyline. We're talking about the selective serotonin norepinephrine reuptake inhibitors. So we are talking about things like duloxetine, Cymbalta, or venlafaxine. But we are not talking about the classic antidepressants, the SSRIs, fluoxetine, escitalopram, and citalopram. These are considered 5th or 6th line in the treatment of migraine. Now, if a patient has comorbid anxiety or depression, fine. They can, of course, be treated, but you still need to treat the underlying migraine. Calcium channel blockers or antagonists such as sibelium or flunarizine, ARBs or ACE inhibitors, so candesartan and ARB is a good medication with a very low side effect profile. Anticonvulsants, but who wants to use valproic acid in young women? And of course, we know that migraine occurs in 75% of the time in women, 25% of the time in men. Topiramate, again, is used for both acute and chronic migraine. And onabotulinum toxin A, Botox, is used only for chronic migraine, and there are some other medications there. We've used these for decades, and we usually follow the rule 50-50. When patients tell us, are we going to get better on these medications? We tell them 50-50. What does 50-50 mean? It means that 50% of the patients, half the patients, will benefit. And the benefit will be a 50% or more reduction in monthly migraine days. That is the best we could do with these medications. The problem with these medications, as outlined in the previous talk, included they take time to titrate and they take a long time to kick in. They have many side effects, mostly unacceptable, mostly related to weight gain, but also to dizziness and cognitive effects and possible teratogenicity for pregnancy and so forth. Of course, sometimes we made use of these side effects. For example, for topiramate, It's a good weight loss agent, so we used it preferentially in many patients because most of the patients, as of most people, are overweight or obese. When we talk about amitriptyline, a tricyclic antidepressant, we used it mostly in patients who complained of insomnia or difficulty falling asleep. And we know that irregular and erratic sleeping patterns worsen migraine. So we try to utilize the side effects, but many patients drop out with these medications. If you look at patients on these medications for a period of 1 year, by the end of 1 year, perhaps only 15–20% of the patients remain on preventive medications. Most of them stop them due to either lack of efficacy or unacceptable side effects. And therefore, these medications, although they're all that we had, gave us a whole lot of problems to deal with. And there comes in CGRP. What is CGRP? Well, CGRP is a 37 amino acid neuropeptide. It was discovered in the late 1980s. It was found that during migraine attacks, CGRP serum levels were elevated, and that when we used medications that were effective in aborting the migraine attack, the levels of CGRP became reduced. So this was discovered already in the late 1980s by taking blood samples from cubital veins and even jugular veins and finding that CGRP level during the acute attack was elevated. It was around the late 80s that sumatriptan, the first triptan migraine-specific acute therapy, was discovered. And when you gave triptans, the migraine went away and the CGRP levels normalized. Researchers also at that time, in the late 80s, early 90s, found that IV CGRP triggered migraine attacks only in patients with a history of migraine headache. And CGRP has not been found to be elevated in patients with chronic tension type headache or with cervicogenic headache. All this information led people to believe that, hey, if we can do something about CGRP, if we can control the level of CGRP, then perhaps we can offer treatment to patients with migraine. Two classes of CGRP-like medications have come to market now. The first are referred to as small molecule CGRP receptor antagonists, otherwise known as GPANs. There are two such agents that have been approved in the US for a little over a year and a half now. The first was ubrogepant, Ubrelvy, and the second one is rimegepant, Nurtec. Both these agents are approved for the acute treatment of migraine. Not prevention, but for acute treatment of migraine, with a twist, and we'll talk about that later. These medicines actually were supposed to come out around 2010, a little over a decade ago. We're very excited about it. Everybody's been waiting for some treatment for migraine. But some of these agents in trials were found out to have some liver toxicity, and therefore many of the trials were discontinued. The trials were reinitiated, different molecules were looked at, which led finally in end of 2019, November 2019, for these medicines to be approved for the acute treatment of migraine with no fear of liver toxicity. Then next came the large molecule monoclonal antibodies against CGRP. Now, these molecules were approved in the US. The first such molecule was approved in the US in May 2018, and it arrived to us here in Dubai in late October of 2018. And two other molecules were approved in September 2018, and yet a fourth one was approved in February 2020. These monoclonal antibodies, and they do not have anything to do with the immune system. A lot of people get this confused, including insurance companies rejecting these medications because they think they're immunotherapies. These are not immunotherapies. They do not work on the HLA system and have no immune effects. And they fall into two categories: those that work against the CGRP receptor and those that work against the CGRP ligand. So the large molecule monoclonal antibodies are either humanized antibodies against the CGRP molecule, and of those we have three: eptinezumab, which is an intravenous infusion, fremanezumab, and galcanezumab. And galcanezumab is Emgality and is available in Dubai, and our previous talk showed us some of the data, are both subcutaneous injections. We also have antibodies against the CGRP receptor that are fully human, and that is erenumab, which is Aimovig, again, a subcutaneous injection. These drugs are intended for the preventive treatment of migraine, Clinical trials for all these agents have been positive without a shadow of doubt. The medications have had excellent tolerability. Patients stay on them. There's very minimal side effects and no serious side effects to speak of. And their adverse event profile, although not the same as placebo, is very similar to placebo. Just like triptans were a revolution for the acute treatment of migraine in the mid-1990s, we can say that these molecules have been a revolution for the treatment, for the preventive treatment of migraine in the late 2018. So, what are the approved CGRP therapies? Well, erenumab is Aimovig. It comes in 2 dosages, 70 milligrams or 140 milligrams, and it's a subcutaneous monthly injection every 28 days. The next agent, galcanezumab, which is Emgality, consists of a loading dose of 240 milligrams subcutaneously and then 120 milligrams subcutaneously on a monthly basis. Both those 2 agents, Aimovig and Emgality, are available in Dubai and have been available for a number of years. Myself, as well as Dr. Abubaker and many other neurologists around town, have had quite good experience with them. They work quickly. Dr. Abubaker had a patient that responded within 4 days. There's very good data to show that they kick in within the first week, and there is subgroup analysis that shows that some of them may even kick in within 1 day, especially when you administer a loading dose. A 4th agent is eptinezumab, Vyepti. The 3rd one is not available in Dubai, so we will not talk about it. But the 4th agent is eptinezumab. It was approved in the US in February 2020. It is not yet available in Dubai. It's a bit different. It's not a subcutaneous monthly injection. It is an infusion once every 3 months. And we hope to have it here in Dubai later this year, perhaps as early as September. With infusion therapy, you can find fast onset of action. All of them have shown pretty good responses in the range shown for Emgality earlier on. Now, I mentioned that GPANs, the small molecule CGRP therapy, are for acute migraine treatment. Well, Rimidgepant, which is Nurtec, is now also FDA approved for preventive treatment. A recent study looked at 75 milligrams every other day for the purpose of prevention. When used for acute therapy, it's used as a single dose of 75 milligrams. I'll say a few words about Rimidgepant since it's the most newly approved medication for prevention, and this is, after all, an update in preventive therapy. It is the first and only FDA-approved medication for both acute and preventive treatment of migraine. Its most common adverse effects include nausea, 2.7% on Nurtec as opposed to 0.8% on placebo. Nurtec is Rimidgepant. Abdominal pain and dyspepsia, again, in 2.4% of patients as opposed to 0.8%. And less than 1% of patients experienced hypersensitivity. So as you can see, this is a very well-tolerated medication. There are, with this medication, some drug-drug interactions that we need to be aware of, and they mainly relate to liver enzyme and the cytochrome P system. So therefore, we need to be very careful when we use it with certain types of medications, and we should do our drug searches for drug-drug interactions to make sure that we're not giving a medicine that either reduces or increases the efficacy of this medication. The side effect profile of the large molecule monoclonal antibodies, one of the good things about them is that there are no drug-drug interactions. And for this agent, there are a few drug-drug interactions, but they are limited. And if we're aware of them, then there should not be a problem. So, do we have any long-term data? I mean, the advantage of the repurposed medications is that we've had them for a few decades, and we know their long-term side effects. How about long-term data for the monoclonal antibodies? Well, there is one study which shows us a 5-year open-label treatment phase of a randomized clinical trial with erenumab, which is Aimovig. And this study actually is by some of the biggest names of migraine around the world. If we look at this study, of 383 patients that were enrolled into the study. So if we look at the graph below, we can see, first of all, the 12 weeks double-blind treatment phase of the study. So in that phase, the 12-week phase, patients were either on placebo, erenumab 7 milligrams, 21, or 70 milligrams. This was a dose-finding study before erenumab was FDA approved. Right now, the approved doses are 70 and 140. Well, after this 12-week double-blind treatment phase, patients were enrolled into an open-label phase extending up to 5 years. 383 patients enrolled, and 215, so 56% of the total number of patients completed the study. Now, this is pretty amazing in migraine medicine. Remember, with the old drugs, after about a year, under 20% of patients were still on medications. In this study, 5 years later, over half the patients were still on medicines, which tells you that this is a very highly efficacious medication that the patients like, and that's why they stayed on it, and that there are really no side effects related to it, so to speak, no serious side effects or bothersome side effects. And this data can be extrapolated to just about all of the monoclonal antibody treatments. Now, what was so good about this study is that at baseline, patients were experiencing 8.7 monthly migraine days. And if you look at 5 years down the line, this was reduced by about 5.3 days per month. And if you look at the graph, you see that with continued use of the medication over time, there is further improvement. Mild, yet there is further improvement. It is believed that chronic CGRP suppression leads to even better efficacy and less migraine headaches over time. Translated, this means that these medications change the underlying pathophysiology of the brain to make it less susceptible to migraine. So we have long-term data, we have good efficacy, we have pros and cons of the old and new drugs. Of course, the new drugs cost a couple of thousand dirhams a month, the old drugs cost a few hundred dirhams a month. So why should we use the new drugs? Why shouldn't we just continue with the old drugs? Well, we mentioned already a lot of the problems with the old drugs. Side effects, tolerability, they take time to act, patients don't stay on them. The newer drugs work fast, very limited side effects, they work well. So is there any other reason? Have we compared them? One recent trial came out called the Hermes trial, and this is the first randomized double-blind head-to-head study comparing Aimovig, erenumab, to topiramate in patients with episodic and chronic migraine. The doses of Aimovig were between 70 and 140. These are the only two doses available. And topiramate was from 50 to 100. They tried to push patients up to 100, but if there was tolerability issues, it would be brought down to 50. 777 patients were enrolled in 82 centers in Germany. These patients experienced at least 4 migraine days per month. And these patients were either naive to Aimovig, or prior other preventive therapy was not suitable for them, or they had failed at least 3 prior prophylactic migraine treatments. The primary endpoint was not efficacy. The primary endpoint of the trial was superior tolerability of Aimovig compared to topiramate, as assessed by treatment discontinuation due to adverse events during the double-blind treatment period. So the secondary endpoint related to efficacy, superiority of Aimovig compared to topiramate in terms of at least 50% reduction in monthly migraine days over the last 3 months of the study. Now, I think we would have liked to see the primary endpoint as efficacy, but perhaps the people who designed this trial were more sure that the monoclonal antibody Aimovig will be much better tolerated than topiramate, and that was their aim of the study. And we know that already from clinical experience. Perhaps they were not so sure that this trial will show superiority of the newer drugs against the older drugs, and that's why they chose that as a secondary endpoint. Well, they were pleasantly surprised with the results. As expected, Aimovig showed superior tolerability and efficacy compared to topiramate, with less treatment discontinuations over the course of the 24-week treatment phase. This we expected, this we knew from our clinical experience. The pleasant surprise came when a higher number of patients in the erenumab group experienced 50% or more reduction in their monthly migraine days compared to those in the topiramate arm. So in addition to tolerability, in addition to faster onset of action, We now have a medication in a head-to-head trial with an older effective medication showing that this new monoclonal antibodies are not only better tolerated, but also statistically more efficacious. Can we combine preventives? There are no good studies out there, but there are limited case series, for example, with chronic migraine. Remember, Dr. Abubaker told us how we define chronic migraine, and that is 15 or more headache days a month, half of which should be migraines. And for that, we use many different migraine prevention, but also Botox, onobotulinum toxin A. And for our very severe debilitated patients with resistant chronic migraines, we have combined at times CGRP-based monoclonal antibodies along with the onobotulinum toxin A. I personally have 3 or 4 patients on this combination. And in the literature, there have been a few case series showing additive benefits by combining 2 medications with 2 different mechanisms of action. Not that anybody really truly knows the mechanism of action of how these medications reduce migraine, with positive results. Of course, why should there be studies? Well, besides knowing if we're doing the right thing or not, you can imagine that the cost of Botox along with CGRP-based monoclonal antibodies is not something that insurance companies like to see on their bills much. So I would like to conclude by saying that migraine is a highly prevalent and complex neurobiological disorders with different mechanisms. CGRP-based therapy is the newest mechanism on the market for which medications is available, but there are multiple other mechanisms for which trials are undergoing with different agents working on PACAP and different neurotransmitters. Mechanism-based therapy for the preventive treatment of migraine is now available. Thank you very much.
We go back now to the questions and answers. So there's a question here: if repeated migraine on specific area is it threatening or not? Usually it's not. So if you have chronic migraine headache, then you will either have chronic or you have acute, and it usually fluctuates. People who have episodic may convert to chronic. Sometimes chronic will convert to episodic. Any other opinion, Dr. Kayed, Dr. Deeb?
I'm not sure what they mean by this. Perhaps what they mean is that if the migraine is occurring on one side of the head all the time, is that threatening? We call that a side-locked headache. Most migraines, if they are unilateral, they have side shift, which means a patient can tell you, 99, 95, 90% of my migraines are on the right, but on 5-10% of the time they're on the left, for example, or they may be global or so. So with migraine, you expect side shift. If you have a side-locked headache, you have to just make sure you're not missing anything. It doesn't mean you have to scan, but you have to make sure that the patient truly fulfills the criteria of migraine and there's nothing else happening. Migraine can be side-locked, but sometimes the patient will have either a bilateral headache or a side shift. I think that's maybe, I don't know if that's what they were aiming at, but that's how I understood the question.
Other side-locked headache are possibly cluster or trigeminal autonomic phalanges, but that's not our talk today. The other question is, what's the role of nutrition in preventing or helping to reduce symptoms? Well, in the book it's written, if you're on good and healthy diet, avoiding high calorie diets or high carbohydrate diets, you may reduce headache, although exercise and good sleep hygiene. That's my opinion. Deeb, your opinion?
This is a long topic to talk about, nutrition in preventing migraine. Only about 30% of patients with migraine have a food trigger. And that's because some people consider alcohol as a food. If you take alcohol out, it'll be even less. So the vast majority of patients with migraine do not have a food trigger. But it is useful to look for triggers. And if they are there are some foods that potentially trigger migraines more than others. And if you can identify them, then by avoiding them, you'll have less migraines. Now, if you're talking about vitamins and supplements for nutrition, there is some evidence for that in migraine prevention, but then we're talking specifically about magnesium, and you have to have the right kind and the right dose. We're talking about riboflavin, vitamin B2, and again, you have to have the right dose. We're talking about Some people have used feverfew and butterbur, which are other kinds of supplements for that, and the coenzyme Q10. These are the ones with some level of evidence in the literature for migraine prevention. But other than that, everything else that everybody does is to me unproven.
I don't frequently send people to nutritionists, and they have some advice which they recommend, and I do see some people have effect on it.
Yeah, it is a food sensitivity, not a food allergy. So it's not really useful to send patients with migraine to get allergy testing. It doesn't work that way. Now you can get tested for everything that you're allergic to, and perhaps if you avoid it, you can have better bowel habits and more energy and so forth. But nobody has proven that specifically for migraine.
So are side effects more common in people who have comorbidity? Of course. I mean, if you have chronic or coronary artery disease or hypertension, you are at more risk of having side effects. Some migraine-specific medications such as Imigran or Zomig, you probably avoid on those who are having active unstable angina. Dr. Deeb, your opinion?
No, that's good. I don't have anything else to add for that.
Okay. Can leave this question to you. Is there a contraindication of giving people who has immune condition, such as CVID or lupus? I guess they meant the monoclonal.
Yeah, no, there is no contraindication. These monoclonal antibodies do not work on the immune system. So we have used them in patients with multiple sclerosis. We have used them in patients with inflammatory bowel disease. We have used them in patients with rheumatoid arthritis. So there's no known contraindication with autoimmune conditions.
Same thing for me here. So best preventive treatment in children?
Well, as you may or may not know, we use pretty much the same medicines we use in adults, but we use them in children and adjust the doses. And then a study came out 3-4 years ago or something like this about two of the most common ones that we use, propranolol and topiramate, and it showed that they didn't do much compared to placebo. So I don't know really if we're doing much to help with that. We don't have good clinical trial data. I sometimes use cyproheptadine, periactin, which is an anticholinergic given at bedtime. There is some evidence for that. It increases appetite, it helps with sleep, and it does side effects, and it does help headaches a little bit. So we don't have data about monoclonal antibodies in children yet. So they're new on the market, but for children, I think we tend to, because parents also want us to, we tend to use alternative measures a lot. We tend to use yoga, meditation. We try to use supplements like the ones I spoke about before. Exercise, please, for everybody, kids and adults. Exercise, exercise, exercise. I've had a patient just a few days ago that I've been treating for a long time for migraines and with all these agents. And then, all of a sudden her migraines got better, a lot better. And she stopped many of these agents. And I said, what changed? She goes, 2 things I've done. Number 1, I started exercising and exercising regularly. And when we talk about exercise, we're not saying walk around the block or around the park or the lake. Really pumping, really aerobic exercise. And number 2, she said, I stopped seeing myself as the victim. I stopped considering myself as a victim of my headache, and I wanted to gain control over my headache. And I think these are 2 important things that perhaps as physicians, we don't tend to stress enough. Now, of course, nothing works for everybody, but you need to empower the patient to take control of their own headaches, and they need to change their lifestyle.
Yeah, I agree with you, Dr. Deeb. There is no classical trial on this, but I've been with headache specialists where I was student or resident. They've been using similar medications. So in my experience as well, people who are 12, 13-year-old, I do see them. I give them topiramate, but lesser dose than the adult dose. And I do see some effect on most of the cases I've seen. But I agree with you, there is no good trial for this. Can migraine induce a seizure? Not to my knowledge, but there is a big trial on migraine associated with epilepsy. And there's talk, if you attend, guys, Dr. What's his name? The epileptologist, Tawfiq Saadi. So he has a big talk on migraine and epilepsy. But to my knowledge, there is no association clearly.
You know, there is one condition called Microlepsy. If you look at the International Classification of Headache Disorders, there's one condition referred to as Microlepsy, which I've never seen a case except for recently. I think I have one case. And this is like a migraine starts as an aura, and the aura somehow triggers a seizure. I've had a patient that came to me after seeing many different neurologists around town, sometimes being diagnosed with migraine with aura, sometimes being diagnosed with epilepsy. And I think she might have microlepsy. I'm not 100% sure, but it seems like she might have that. So it's a very, very rare condition.
Yes. It's only mentioned in Dr. Tawfiq Sadi's lectures.
Migraine triggered seizures, yeah, but it's in the International Classification of Headache Disorders, migraine triggered seizures, yeah.
So the same question about migraine children, we answered it. How do you prevent or how you treat rebound headache, or I guess they meant medication overuse headache?
You're always talking about medication overuse headache, Dr. Abubaker, so I'll leave that to you.
Okay, so number one is lifestyle change. So you stop or reduce, taper the offending agent. I have rule of thumb as per migraine guidelines. If you're using any analgesics more than 12 tablets or 12 days per month, then you are at risk of having medication overuse headache. So try to minimize it to less than 12 tablets or 12 days per month. So that's number one. So if you're taking naproxen, for example, you change it to paracetamol, but still you have to still use it for less than 12 days per month. Along with this, you can try to bridge it with either steroid or give botulinum toxin or monoclonal antibody or other oral preventive medications. So that's the mainstay of treatment. Other thing you want to add, Dr. Khalid?
No.
Okay. So we have a last question here.
The first question said, is it NHRA approved? I wonder what NHRA stands for. I don't know what that means.
Well, where is this? NHRA?
It's the first question, and it says, is it NHRA approved? Do you know what NHRA stands for?
NHRA, no clue.
Okay.
Okay. If the calcium blockers or amlodipine can be used for migraine prophylaxis, is there any published studies?
Well, there is Flunadine is a calcium channel blocker. That's Sibelium. It wasn't available in the US, but it was available in Canada and Europe. I'm not familiar with the study data, but it is used, and we do use it sometimes for migraine with aura and migraine-related vertigo as well. There is some very weak data for verapamil, but I'm not aware of any data for amlodipine.
I've seen people who are being treated with amlodipine for their hypertension. They have noted that their headache frequency are reduced, but that's personal level though. What's the relation between migraine and hypertension? Well, there is no clear relation, but if you are prone to have hypertension and acute headache, you may have, I've noticed that high blood pressure. Well, there are something called migraine mimickers, right? So you can have subdural hematoma or subarachnoid hemorrhage, and you may think that's migraine. So if you're changing in the nature of your migraine headache, they think about other mimickers. But clear association with hypertension, I'm not aware of. Dr. Deeb?
Hypertension, of course, can be associated with headache. Hypertension is known as the silent killer, so you don't have to have any symptoms to have hypertension. If you look at the International Classification of Headache Disorders, we divide headaches into primary or secondary. The primary headaches are migraine, tension headache, trigeminal autonomic cephalalgias, and other primary headaches. The secondary headaches, there are about 8 categories, and one of these categories is headache related to homeostasis, and one of those categories is uncontrolled hypertension. That is how headache and hypertension is linked, but not necessarily migraine and hypertension.
This is a good question here. Is pregabalin used to prevent migraine?
Used, yes. Any evidence for it? Not much.
Yeah.
At one point, I think gabapentin was in the, if you look at migraine prevention approved medications according to the American Headache Society, American Academy of Neurology, and the Europeans, I think gabapentin was at the bottom of the list at one point, but I don't remember pregabalin being in there. Now,
I agree. But sometimes I've seen people who have migraine superimposed with occipital neuralgia, for example, or cervicalgia. Then those cases, maybe pregabalin helps.
And pregabalin also is a mood stabilizer. You know, pregabalin is also a mood stabilizer, you know, used by psychiatrists sometimes. And we know that 20% of patients with episodic migraine have a comorbid psychiatric condition, depression, anxiety, or something else. And if the patients have chronic migraine, 40% of episodic migraine patients. And if you have chronic migraine, you have a 60% chance of having a comorbid anxiety, depression, or some sort of psychiatric condition. So Lyrica can have positive effects on anxiety and things like that.
Are there precautions or interaction between COVID vaccines and migraine? The answer is no, but we know that by experience that COVID vaccine sometimes could cause or trigger headache, and sometimes it may trigger migraine headache as well. So I've seen some people who are having increasing headache relating to vaccine. So in those cases, if you're having episodic migraine, for example, you may need to use preventive medicine. What do you think, Kai? Dr. Kai?
Yeah, I think the same. Any vaccine can result in headaches and flu-like symptoms, whether it's the flu vaccine, the COVID vaccine. So somebody with pre-existing migraines can have worsening of the migraine. Somebody with no headaches can have new onset headaches. So it's it's just like any other vaccine. I don't think anything specific about COVID-19 vaccine.
So you love this question, Dr. Deeb. What is the treatment for migraine which comes with vomiting?
Okay, so as you saw in the criteria, nausea and vomiting can accompany migraine attacks. So vomiting, I think you have to divide it into 2 segments. Does the vomiting come on as one of the very first or early signs of migraine, or does it come only as the migraine intensifies? If the vomiting comes at the very beginning, then of course it's useless to take oral medications, and therefore you have to discuss with the patient non-oral routes of administration of medication. So you can use sumatriptan nasal spray. In other countries, they have other nasal sprays as well, like DHE and maybe zolmitriptan nasal spray. You can use suppositories. You can use like diclofenac suppositories. You can use sumatriptan injections. So you will have to use medications with a non-oral route if vomiting comes at the very beginning. Now, if vomiting happens because of intensification of headache, and we get migraine patients that tell us, you know, the headache starts a little bit, but when it becomes intense, that's when I have nausea and vomiting. And then of course, you should treat the migraine early to try and prevent that. Now, for nausea, metoclopramide, Pramosan or Primparan, as it's also known, is a very good agent. There was an emergency room study in which they took patients with acute migraine headache, and they gave half of the patients IV metoclopramide, so just an anti-nausea medication. And they gave the other half IV morphine or sub-Q morphine. More patients on the IV metoclopramide had headache relief. We're not talking about nausea and vomiting, headache relief, than the patients who received morphine. So I usually tell patients that metoclopramide, it's a dopamine 2 receptor agent, can do 3 things for you. It can prevent nausea from coming, or if you have nausea already, it can reduce it. Number 2, during a migraine attack, there's usually slowing of peristalsis and slowing of absorption of the medications. So when you give something like metoclopramide, it can help with the absorption of medications. And then number 3, it has a mild headache relieving property by itself. So some patients with difficult to control headaches, I tell them to take a cocktail of 3 medications when they have their migraine attack. to take a non-steroidal anti-inflammatory, usually naproxen or something else, Voltfast, which is fast relief diclofenac, along with metoclopramide, along with a triptan, whichever triptan works best for them.
Okay. Great. So that question implicates that, can extreme happiness produce migraine? Not to my knowledge, but I know that emotional liabilities, stress, and anger may aggravate migraine, like any other diseases. But extreme happiness, so probably the emotional liability part of it may provoke it, but I haven't seen any data for this.
I want to know how to achieve extreme happiness. Okay. No, but Dr. Abubaker, you know that the brain of patients with migraine is very sensitive to change. So people with migraine, too little sleep can trigger their migraine, too much sleep can trigger their migraine. So they're sensitive to change in sleep pattern, eating pattern, and as you mentioned, mood and emotion. And therefore, extremes of anything just messes their brain up and it manifests with migraine. Yeah.
So that's another question which is very good. Vertiginous migraine, what's the treatment? So usually the treatment is asked for migraine headache. So you give the preventive medicine, but it's proven in some study that nifedipine may be very helpful for vertiginous migraine. But you should be fulfilling the criteria of vertiginous migraine. Dr. Deeb?
Yeah, it's true. I also use Sibelium for that. You know, the criteria for there's many different words for it: vertiginous migraine, migraine-related vertigo. There's a third term, I forget what it is. But if you look at the international classification of headache disorders, it's not in the main classification criteria. It's in the appendix. And what do they have in the appendix? In the appendix usually includes migraine categories for whom the migraine experts around the world, therefore not Dr. Abubaker or Dr. Kaid, but the big migraine experts around the world have not yet agreed fully on the diagnostic criteria for vertiginous migraine. So it's not that everybody with migraine who has vertigo has vertiginous migraine. They're trying to come up with certain criteria. Of course, we see dizziness and vertigo as accompaniments of migraine very often, especially when it intensifies. I don't think there are very good studies to tell us what medications to use. We can use all the medications we use for migraine. I personally like Flunadine, Sibelium. Others may like other agents.
The problem is Flunadine is not available everywhere. I attended one lecture.
It is. You can find it. Come to yes, City Hospital, and others. Dr. Tawfiq has it as well.
A lecture who was attended by an expert in migraine with vertigo. So actually, the vertigo may happen. Any type of vertigo could happen in migraines. So positional type, non-positional type. Usually, it may last for 5 minutes to 1 hour, but sometime in most cases, severe scenario may last for 3 days actually, or sometime for days and days, if it's status. So what's the best treatment for catamenial migraine? Usually I use NSAID during the menstrual period, or you can use sometime preventive medicine along with it, like days before the menstruation and days after the menstruation along with it. Do you have any other idea?
Again, if we go to the classification scheme, catamenial migraine, it's actually catamenial epilepsy. When it's migraine, this is in the appendix. It's called migraine, menstrually related migraine or pure menstrual migraine. Pure menstrual migraine is when the woman experiences migraines only in relation to her menstrual period in at least 2 out of 3 menstrual periods and at no other time. That's called pure menstrual migraine. And the menstrual migraine is from -2 days up to 3 days of menses. Menstrually related migraine means that the woman experiences migraine around the time of her period, but also at other times. Again, this is in the appendix. We see it, we recognize it, but its treatment is nothing more special than the regular migraines. As you mentioned, sometimes we use continuous medications for a few days, whether it's non-steroidals or long-acting triptans. I don't have access to Triptan here. It's actually FDA approved for that purpose because I don't have access to it here, so I haven't used it.
Does fasting increase the severity of migraine? Yes, of course. And why? Because this is commonly one of the triggers who may provoke migraine. We know that some food that triggers baro changes, a change from cold weather to hot weather, a rainy situation, or rainy temperature may aggravate sometimes migraine. Any idea, Dr. Deeb?
The only thing I have to say is don't think that it is the drop in the glucose that really worsens the migraine, because we see patients, diabetic patients, coming with hypoglycemia and they don't have headache. So hypoglycemia in of itself does not cause migraine or trigger migraine. Now, in a patient who has migraine, hypoglycemia may act as a trigger. Now, that's something different. Yeah.
Okay, that's an interesting question. A stroke complication of migraine, is it real issue? Was per book, if you have cryptogenic stroke, meaning that you don't have a cause of the stroke, we have raised, it has been raised actually, that migraine with aura may provoke stroke. Any opinion, Dr. Khalid?
Yeah, I mean, it's usually, as you said, migraine with aura. A migraine without aura is not usually a risk factor for stroke. But this is where I'd like to say one thing. If you are a woman and you have migraine with aura, please don't smoke. Because although the risk of stroke in women with migraine with aura is very, very small, you increase that risk is very small. You increase that risk several fold if as well you smoke. Shisha is also smoking, by the way, just in case you are doubting it. And if you are on high dose estrogen oral contraceptive pill. Luckily, these days, most of the combined oral contraceptive pills are low dose estrogen. So that should not be an issue.
Okay. Is the use of diclofenac and ibuprofen is the same effect as naproxen? Well, if you're basing on study, to my knowledge, naproxen is the only studied one to treat for acute migraine. But in my opinion, I've sometimes used ibuprofen and diclofenac, and they're as good as naproxen. What do you think, Dr. Khalid?
I'm not aware of the data comparing the different non-steroidals. The only reason that naproxen sometimes is favored is because of its longer half-life, maybe 8 to 12 hours compared to ibuprofen, which is 4 to 6 hours. And also its lesser GI side effect compared to something like diclofenac or so. But although I sometimes tend to prefer naproxen, if the patient gets the same or better relief with ibuprofen or diclofenac, I have no problem with that.
Okay. So when you use botulinum toxin to treat migraine?
When the patient has too many wrinkles. Yeah. So botulinum toxin is only indicated in chronic migraine. So chronic migraine is 15 or more headache days a month, at least 8 of which, at least half of which are migraine days. So in those patients, you need to use preventive therapy, and onobotulinum toxin A is one of those preventive therapies.
And the upside of botulinum toxin that you're using it every 3 to 4 months sometimes. So that's good for those who are having chronic migraine. I think we ended up the questions. Thank you very much, Dr. Deeb, for attending this session. It's a very nice and illustrative talk. I hope we see each other again in next talk next week.
Thank you, Dr. Abubaker, and thank you for all the attendees.
Thanks. Bye. Have a nice day.